Good evening all. We from Department of Pediatric Surgery welcome you all to this academic session, the case presentation on neonatal cholestatic jaundice. Today we have a guest faculty, Dr. Sanjay Rao sir. Sir, good evening. Dr.Ramesh Srinivasan sir, good evening. Now I hand over to Anjana, Dr. Anjana. She is going to introduce our guest for today. Anjana.
Good evening,
over
Dr.
to
Sanjay
Anjana.
Rao.
Yeah, good evening, Dr. Nandikumar. Good evening.
Good evening, Dr. Ramesh.
Good evening, sir. Good evening.
Yeah. Go ahead, Anjana.
Dr. Anjana.
Good evening, one and all. I am Dr. Anjana, first year resident. On behalf of Department of Pediatric Surgery in Nilofer Hospital Institute of Child Health, I welcome you all for today's case discussion on neonatal cholestatic jaundice. Before we begin our case discussion, I would like to welcome our guest faculty. Our first guest faculty for today is Dr. Sanjay Rao, sir. Welcome, sir. Dr. Sanjay Rao, sir, is a senior consultant pediatric surgeon and head of department at Narayana Health City, Bangalore. His field of expertise includes pediatric solid organ transplantation, pediatric airway surgery, and pediatric minimal access and robotic surgery. We welcome you, sir. Our second guest faculty for today is Dr. Ramesh Srinivasan, sir. Dr. Ramesh Srinivasan, sir, is a pediatric gastroenterologist at Apollo Hospital, Jubilee Hills, with over 25 years of experience in the fields of pediatrics, pediatric gastroenterology, and pediatric gastrohepatology. Welcome to today's case discussion, sir. We will now proceed with the case presentation on the topic of neonatal cholestatic jaundice.
Good evening, sir. This is Dr. Harisha, final year resident. Shall I start, sir?
Yeah, go ahead.
Yes, sir. 4 months old female Muslim child Atika Fatima, resident of Falaknuma, with informant being mother, who is a reliable informant, brought the baby with chief complaints of passing pale colored stools since birth and yellowish discoloration of eyes since 1 week of life. History of present illness. Baby passed a normal meconium immediately after birth, 1 day after which the stools were pale colored. After 1 week, mother noticed yellowish discoloration of eyes, light yellow colored, which was persistent and non-progressive. History of passing dark urine with diaper staining 10 days after birth onwards. There is no history of phototherapy. There is no history of fever, no history of excessive cry, no history of irritability, no history of refusal of feeds, no history of blackish discoloration of stools, no history of bleeding from injection sites, no history of abdominal distension or abdominal fullness, no history of blood transfusions, no history of vomitings or diarrhea, no history of constipation, and no history of seizures. Antenatal history. It's a non-consanguineous marriage, and the case was antenatally registered. In the 3rd trimester, mother had fever with rashes, and all the antenatal scans were normal. Coming to perinatal history, birth order of the child is 2nd, and baby was it was a term delivered by lower segment cesarean section. Baby cried immediately after birth with birth weight of 2.9 kgs. There is no history of phototherapy or any NICU admissions. The jaundice was conservatively managed with oral medication, and the child was exclusively breastfed. Immunization history. Child was immunized up to date as per the immunization schedule. Drug history. Vitamin supplements and antibiotics were used for the present complaint. Family history. there was no similar history in the family or the sibling. Coming to general
Yes,
examination.
No, I think
just
can we,
wait.
yeah, I think just hold on. Yeah.
Hold
Yes,
on.
yes, sir. Yes, sir.
Yeah. So I think, you have, so what goes through your mind? So from the history, when you see this child, I mean, this you're presenting as a long case, isn't it?
Yes, sir.
Yeah. So what is your thinking process? What are you thinking when you see this child and you've got this history? What is it that is going through your mind? What are the various diagnoses that you're thinking about?
Based on the history which mother has given, that the child passed pale color stools after passing normal meconium, sir. So there's no in.
No, don't get very
So
confused. See,
it
this
was
is a child. This is a baby who has jaundice, isn't it?
yes, sir.
Yeah, and it's a baby who has jaundice from early infancy, from whatever you're describing.
Yes, sir.
Yeah, so when you as a surgeon, you're going to go out and you're going to practice. So when a child like this is referred to you, what are the various things that you need to think about? What are the various differential diagnoses that you think about? It's not very complicated. Don't make it complicated.
Yes, sir. Because the
Yeah.
child has been passing ecolic stools since birth. So being a surgeon, my main thought process comes to end up in biliary atresia, sir, extrahepatic biliary atresia.
That's not the way. Now the child has jaundice. You have to
Yes, sir.
determine what kind of jaundice is it. Do you think it is
Yes,
a
sir.
cholestatic
Jaundice.
jaundice, or do you think it is a non-cholestatic jaundice? And if so, why?
Yes, sir. Mother has noticed yellowish discoloration of eyes after 1 week after birth, sir. So
why is it not just physiological jaundice then? Prolonged because the baby is on breastfeed, no?
Yes, sir. But the child has been passing ecolic stools also, sir.
Okay, so good. So one child has ecolic stool. Anything else? You mentioned it in the history.
Yes, sir. And
what other parameter?
And the jaundice has been non-progressive and persistent. That is still present, sir.
No, any other parameter to suggest that? No, any other parameter to suggest that this is a obstructive jaundice or a cholestatic jaundice? You said one jaundice. You said pale stool.
Dark-colored urine, sir. Dark-colored urine with diaper staining, sir.
With staining. Yeah. Why does that happen?
Because there's no because of the excretion of urine.
So there are bile pigments that are being excreted, isn't it?
Yes, sir.
Yeah. So for the following reason,
other PGs also can answer.
Oh, okay. I'm sorry. Yeah. Yeah. So here you have a child who has jaundice, and you have determined that this child has cholestatic jaundice.
Yes, sir.
So when you have a neonate with cholestatic, so that is how you have worked your head. That's what has to go through your mind. So here is a child with jaundice, and based on the history, I think that this is cholestatic.
Yes, sir.
So if it is cholestatic, what are the various differential diagnoses for cholestatic jaundice in a small infant?
So
maybe if there are 3-4 students, I think you tell one and then pass it to the next one and the next one.
Yeah, that's true.
So what's the most common?
it is obstructive jaundice, sir.
No, they are all obstructive jaundice. All these patients, or this year, you have decided that this baby has neonatal cholestatic jaundice.
Yes, sir.
Yes. So what are the various pathologies or diseases that can cause this presentation?
So,
Dr. Sukumar. Dr. Sukumar.
Hello, sir.
One of you can answer if there is a.
Sir, extrahepatic biliary atresia.
Correct. So extrahepatic biliary atresia is one possibility.
Yes,
What
sir.
other diseases can present like this?
Choledochal cyst, sir.
Very good. Neonatal choledochal cyst could present like this. Then,
Allergic syndrome, sir.
okay, they are a little, they are a little slightly different pathology. So these are what are called hypoplasia syndromes. Okay.
Inspissated bile syndrome, sir.
Okay. Less common. What else do you see? One more you can tell us. And then,
Neonatal hepatitis, sir.
okay, neonatal hepatitis. Again, not typically cholestatic, but okay, let us keep it down in the list. One other pathology. Suppose this baby had abdominal distension at birth.
Spontaneous bile duct perforation.
Very good. Spontaneous bile duct perforation. So these are 2 or 3 differential diagnoses surgically that you have to keep in mind. Biliary atresia, choledochal cyst, spontaneous biliary perforation, and then all the others, hypoplasia and all that are, you have to have specific features to say that. Neonatal cholestasis is another basket, which is a separate sort of thing. We will not go there now. All right. So these are the various things that you have to tell, or these are the various things that you have to think. So what happens is when you list your history, you just list it as a theoretical set of problems. Not this, not this, not this, not this, not this. What we are looking at as examiners is that you have gone through this thinking process. You are not doing it in a mechanical manner.
Yes, sir.
You understand? Okay. So what else is missing in your history? Now, suppose you have to think about biliary atresia, choledochal cyst, spontaneous perforation of bile duct, allergic syndrome, neonatal cholestasis, or the 5 differential diagnoses that you have given.
Yes,
So
sir.
what is there or not there in the history that would indicate one of these pathologies? Some things that you have not mentioned. For example, you said that in perforation, bile duct perforation, you might have ascites. So you have generalized abdominal distension. So there is no abdominal distension.
Yes, sir.
So, and you also have the benefit of 4 months of history. You are not seeing the baby at birth. So what has happened during the 4 months? What is important here? How does a baby with, say, biliary atresia differ from a baby, say, with neonatal cholestasis, for example? Is there a gross difference in the way the baby has behaved, grown, thrived, etc.? Generally, again, as these are all just rules of thumb, they are not.
Neonatal hepatitis babies are usually sick, sir.
Okay. So what does that mean when you say sick?
They're not well preserved.
Yeah. So how has the child developed over 4 months? Has the child gained weight adequately? Has the child's development been all right? Has the child achieved milestones that are relevant to the child's development? So these are important.
Yes, sir.
So if you have somebody who has not developed milestones properly, who has had delayed milestones, or who has had failure to thrive, then these have implications on management and treatment. So I think this is important. You have to put this in your history.
Yes, sir.
Okay. All right. So from your history, you have now these following differential diagnoses. You have decided that it is neonatal cholestasis. And for neonatal cholestasis, you have said it could be biliary atresia, it could be choledochal cyst, it could be perforation, it could be biliary hypoplasia, or it could be neonatal cholestasis. The 5 things that I have written down from whatever you mentioned. Is that correct? Or do you want to add or subtract anything?
That's all for now, sir.
That's all. Okay. So now when you do your his presentation, or when you do your examination and your summary, you have to be able to narrow down on these. So now you have 5 different things. You have to be able to narrow down as you go through examination and through your discussion. Yeah.
Okay, sir.
Yeah. Okay. So go ahead.
Yes, sir.
Dr. Harisha, 1 or 2 more things. Are you able to hear me? This is Ramesh Srinivasan here.
Sir.
See, in the history, you clearly mentioned that the failed stools have been for the last month, and the baby is 4 months old now. Is that
Yes,
true?
sir.
Yeah.
So
for the
Passed normal meconium.
normal meconium. And the pale stools were almost for a month before they had come to you at the age of 4 months.
For 4 months, sir. Since birth, the baby has been passing ecolic stools, sir.
Right from the beginning, baby has been passing it.
Yes, sir. Yes, sir.
So that's important, yeah. And the antenatal history, maybe we have to elaborate a little more. Was there any pregnancy-induced cholestasis and this rash, what she had in the last trimester? What were the other features of the rash? Was there high temperature, any lymphadenopathy, any
I
particular treatments she had taken for that?
Yes, sir. I tried asking mother, but she just mentioned that she had fever with rash, and there was no treatment given for that, sir.
One important aspect of history is noting history of perinatal asphyxia. Did the child have asphyxia? That is very important for us, and we have to clearly mention because the shock liver sometimes starts becoming cholestatic. That is very important.
Yes, sir.
Okay.
Here the child had smooth perinatal transition, sir.
Yeah. All right.
Yeah, please go ahead.
Okay, sir. Coming to the general examination, the child is conscious, alert, well built and nourished. Icterus is present involving the sclera. There's no pallor, no cyanosis, no clubbing, no generalized lymphadenopathy, and no edema. Vitals, baby is febrile with pulse rate of 125 beats per minute and respiratory rate of 28 per minute. Anthropometry, the weight of the child is 5.5 kgs and the height is 64 centimeters. Head circumference is 42 centimeters.
So are these appropriate for the child's age?
Yes, sir. Yes, sir. Hello.
Sorry, yeah, go ahead. Who's speaking?
Sir, all the parameters are appropriate for the age, sir.
Okay.
Coming to head to toe examination, the child has no syndromic features and there are no signs of ecchymosis and petechiae.
No, what do you mean when you
look? What syndromic features did you look for?
For Alagille syndrome, sir.
What syndromic features do you see in that?
Triangular face, sir. Broad forehead with flattened nasal bridge and with loss of buccal pad of fat, sir. And
yeah, so these are things that develop over time. It is very difficult to make out at a child who's 2-3 months old unless it is really remarkable.
sir.
Okay, so you look for features, anything obvious suggesting Alagille syndrome. Over time the features become more coarse. Any other thing that you look for?
We'll look for
When you say
scratch
syndromic
mark.
features,
Sir.
syndromic features, when you say any other syndrome that you look for that can be associated with all these problems? Common
syndrome associated with cholestasis. Other PGs?
It's a common chromosomal anomaly that you see with lot of surgical problems associated.
Prolonged cholestasis.
Dubin-Johnson syndrome.
No, don't go there.
That also starts with D.
Down syndrome, sir.
Yeah, Down syndrome. So don't use terms like syndromic features. It's not good. So if there is something specific, you say that there is something specific I have found. So you say things like dysmorphism or there is some specific finding. Syndromic features is a very coarse kind of term. It's not good and nobody likes to hear it if you say your child doesn't have syndromic features.
And sometimes a better word to use is no gross dysmorphology or dysmorphic features.
I agree.
Okay, sir.
Okay, so no signs of ecchymotic petechiae. All right. So where did you look for edema in this child?
Pedal edema, sir. Like if there is any hypoproteinemia, there will be generalized edema, sir.
No, you mentioned no cyanosis, no pallor, etc., etc.
Yes, sir.
So you said no edema. So where were you expecting edema?
Pedal edema, sir.
Is that so? Does anyone, if your colleagues want to add something or have another opinion? I was told there are 3-4 other PGs also. I can't hear anybody.
Yes, Sukumar, Philip.
Oh, the ankle, sir.
Where do you typically see in a child? This child is supine, isn't it? This child is not standing erect. This is not a walking, talking child. Yeah.
The dependent edema will be there.
Independent, yes.
Yeah. So where?
Sir,
What is sacrum?
Sacral area.
Pre-sacral or sacral area. Okay. All right. Fine. So there was no edema and everything else looks all right. Okay. Go ahead.
Yes, sir. This is a clinical picture of the child, sir.
Okay. Child looks remarkably well preserved. Yeah. All right.
Yes, sir.
It's still icteric, is it?
Icteric, sir.
Okay. All right. Yeah. Please go ahead.
Yes, sir. Coming to abdominal examination, on inspection, abdomen is protuberant, umbilicus is everted, and there are no visible dilated veins or ecchymosis. Flanks are free, hernial orifices are free, and female external genitalia appears to be normal.
What is that word protuberant? Harisha?
Sir,
How
You
will you
think it is-
describe abdomen in an inspection?
it should be either scaphoid or flattened or distended, sir.
What do you
What is
mean
your-
by protuberant?
You have seen
Go
so
ahead,
many
sir.
babies, no? Yeah, sorry, you have seen so many babies so far, isn't it? In
Yes.
your practice, yeah.
Yes, sir.
So does this abdomen look abnormal to you?
No, sir, it was normal. But then I couldn't even put that it is flat abdomen, sir.
Yeah. So if you feel, see, this is that's why I said what's happening is the sense I'm getting is that you have got a checklist and you're trying to tick boxes. You know. So if you say it is normal, say it is normal. Because
Okay,
you
sir.
use a term, then you have to justify the term. So you say on inspection, abdomen looks normal. Or if you feel that the abdomen is distended, say it is distended. You will very
Okay, sir.
rarely find a scaphoid abdomen in a small baby, you know, unless the child is really, really malnourished. You know.
Yes, sir.
Yeah. So if it's normal, say it's normal. Do you think it is distended?
No, sir, it's not.
Because if you say abdomen is protuberant, distended, umbilicus everted, what is the likely cause?
Ascites might be there, sir.
Ascites might be there. So this child's abdomen looks pretty normal, isn't it?
Normal.
Doesn't look stretched, doesn't look anything. Umbilicus also looks reasonably okay. All right. All right.
Yes.
So when you say dilated veins, what were you looking for?
So any signs of portal hypertension, sir?
Yeah. So where were you looking for, and what veins were you looking for?
So around the umbilicus and spider.
What do you call that?
What's that called?
Caput medulla.
Caput medullus.
Let me say, okay. You have seen other children with biliary atresia,
Yes, sir.
and you have done adult surgery. You've done adult surgery. You have seen adults with liver failure or with liver disease.
Yes,
Or you
sir.
must have read, isn't it?
Yes, sir. Yes, sir.
Yeah. So you mentioned spider nevi. You mentioned how many babies of biliary atresia you saw actually had caput medullae?
None, sir.
None. So why do you think? Because it's a list that is always said. You always say there are no dilated veins, there is no caput medullae. You know. So why is it that these things are described but you don't see it here? Every book you read will tell you all these signs of portal hypertension, isn't it?
Yes, sir.
And liver failure, you know, spider nevi, caput medullae, all those things. But you rarely see them when you see babies with biliary atresia. So why do you think that is? Where do you typically see them? What condition is it typically described? Not in children. These kind of caput medullae, spider nevi, you know, flapping tremors, palmar erythema, all that is described classically in which condition?
Okay, so hepatic and
Is it a pre-hepatic, hepatic, or post-hepatic?
Hepatic.
Hepatic. Okay. So basically, when you have cirrhosis of liver
Cirrhosis.
over a long time,
Chronic.
it takes long time to develop. Whereas these children don't give you that time. So a lot of the features that you list as a routine mechanically, so you must understand that they are not common.
Yes, sir.
So if they are not visible, why are they not visible? Probably because there is simply no time. It has not had time to develop. So by that time, the disease kills the patient. Whereas somebody who has got alcoholic liver disease and cirrhosis, they will be cirrhotic for years together. So all these features have time to develop. Okay.
Yes, sir.
So please, what I'm trying to stress is don't tell things mechanically. Each thing has some relevance, and you must understand what that relevance is in the scenario that you are talking about.
Yes, sir.
Okay. And when you say flanks free, what do you mean?
That means there's no gross ascites, sir.
No, sir.
Not
Okay.
to be
Means
mentioned.
flanks are normal. Okay. All right. Okay. Go ahead. Yeah.
On palpation, abdomen is soft. There's no local rise of temperature and no tenderness. There's hepatomegaly. Liver is firm in consistency with smooth surface, and it is regular and rounded. Lower margin is felt 2 cm below the right costal margin at midclavicular line. It is non-tender and non-pulsatile on palpation, and there are no other palpable masses.
So what other palpable mass were you looking for?
Spleen, sir.
Splenomegaly.
If there is any splenomegaly.
So say it. Say it. It is relevant here. Don't make a generic statement.
Yes, sir.
So say that there is no splenomegaly. Yeah.
Yes, sir.
Okay. So fine. So okay. Go ahead.
Just one interruption, sir.
Yeah, please.
With your permission, Harisha, what do you expect in external genitalia in inspection? What do you want to see in a cholestatic jaundice? You have said 5 possibilities.
Yes, sir.
Any other PGs? What do you see in external genitalia? Okay. In case of spontaneous biliary perforation, you can see bile collection and hydrocele in the scrotum.
Okay,
Go ahead.
sir.
Right.
So does the fact that the spleen is not palpable worry you?
No, sir.
Okay, we'll come to this. Yeah, keep going. Yeah.
Harisha Sar is asking relation between biliary atresia and spleen. Can any splenic anomalies occur?
Yes, sir.
Asplenia.
Polysplenia and asplenia or double spleen.
So asplenia is
Yes, sir.
no
It's
spleen.
a point of worry. Yes, sir.
Yes. So the question is for that reason. It is to ask you whether you know that there are a problem, that there are some children with
Associated.
biliary atresia who have problems with their spleen.
Yes,
Okay.
sir.
Yeah. Go ahead. If the spleen is large, what does it tell you?
It means the condition is progressing, sir. Like
No. What does it tell you? If you have a large spleen in this background of cholestasis, cholestatic liver disease, you have large spleen, what could be the possibilities? What's the commonest reason you see large spleens? Surgical condition.
hemolytic anemia. No,
Surgical
sorry, sir.
condition.
Portal hypertension.
Portal hypertension.
Very good. So one, it could indicate that there is portal hypertension. Second, if you have large liver and large spleen, what would it indicate to you?
Sepsis, sir.
Okay. Anything else? Something is filling in the spleen and the liver. That's why both are big.
Something is storing.
Autoimmune.
Storage disorders. Okay.
Storage
Galactose-
disorder.
Glycogen storage disease.
Yeah, so various
Galactose-
storage disorders. Yes, so storage disorders. That we will not go too much into the medical details. So if you have this, so if you have a very large spleen, it could be portal hypertension. If you have large spleen and large liver, it is probably some storage disease, and you have to think about it and involve your pediatric colleagues. Yeah.
Yes, sir.
Okay, go ahead. So no shifting dullness. Yeah.
On percussion, there is no shifting dullness, and on auscultation, normal bowel sounds are heard. No bruit heard. Other systemic examinations, cardiovascular system S1, S2 heard. No murmurs. Respiratory system, bilateral air entry present, and lungs are clear. CNS is normal, and musculoskeletal system is normal, sir.
Okay. All right.
So
Yeah,
at the end of my case history, I like to summarize my case. Is this 4-month-old female child with no significant perinatal events, with chief complaints of passing pale-colored stools since birth, and mother noticed yellowish discoloration of eyes and passing dark-colored urine from first week of life. There's no history suggestive of failure to thrive and liver failure. Examination findings of jaundice with hepatomegaly, no splenomegaly, and no signs suggestive of liver failure. My provisional diagnosis, my differential diagnosis here would be extrahepatic biliary atresia, or neonatal hepatitis, or choledochal.
Yeah, I mean, you had 5 differential diagnoses earlier, which I probably
Yes,
would
sir.
like to stick to.
Spontaneous biliary perforation. Yes, sir.
Yeah. So again, when you are approaching, see, the general tendency when this happens is a patient will be sent to you with by a pediatrician or by a pediatric gastro person. All right. So they send it to you to think about surgical conditions. They will have thought about neonatal hepatitis. They will have thought about medical conditions. They will have thought about storage diseases. So you must know, yes, these things exist. But you as a surgeon have to focus on what is your core competency. So your core competency, or the reason they are sending it to you, is there a surgical problem? All right.
Sir.
So in differential diagnosis, list the surgical problems. And then, yes, there are also these medical conditions that we need to think about. So you said by biliary atresia, choledochal cyst, biliary perforation, in that order of frequency, that is common.
Yes, sir.
Then other things, hypoplasia and all that are the things that you will diagnose as you go along. They are not diagnoses you make when you see the patient the first time. All right.
Yes, sir.
And then all the neonatal hepatitis syndromes, which have so many different other causes. Okay, so fine. So I think you have done well so far, and your summary also is good. So you're halfway through. All right.
Yes,
yeah. So what are you going to do now?
So I want to further investigate the child, sir.
So have you been able to rule out any of your 5 differential diagnoses that you made so far? Can you rule out anything? You had biliary atresia, choledochal cyst, spontaneous perforation of bile duct, then hypoplasia syndrome, and neonatal cholestasis or neonatal hepatitis syndrome. So can you rule out anything?
Spontaneous biliary perforation can be ruled out.
Probably you can, because there is no gross ascites, so that is less likely. Fine. So now you are left with 4 differential diagnoses. So now you have to go forward. Yeah. So what are you going to do?
So I want to get some investigations done, sir. I want to work up the child with routine blood investigations first.
So are you going to admit this child, or are you going to work up on an outpatient basis?
Because child is well preserved and is not sick, sir. So I'll work up on outpatient basis, sir.
Okay.
Dr. Harisha, are you really worried about the age of this child? Do you have any sense of urgency about how you want to do the workup? Is it really quick you want to do it, or you want to take time and do it?
Yes, sir. Yes, sir.
You think 4 months complete, yeah? That brings about a sense of urgency about your whole workup, would it?
Yes, sir. There's a need to operate as early as possible if it is if the diagnosis comes out to be biliary atresia, sir.
Considering you want to number 1 diagnosis, maybe you're a little more concerned at this stage, aren't you?
So the message that Dr. Ramesh is trying to tell you is that there is urgency here. You don't want to, prolong the whole thing. Come tomorrow, come after 1 week. You have to do whatever you are doing quickly.
Yes, sir.
Yeah. Okay. So what are you going to do?
I'll first admit the child, sir.
All right.
And then I'll get the investigations worked up, sir. First with blood investigations, complete blood picture with hemoglobin total
Does somebody
leukocyte.
have the lab reports?
Yes.
Can somebody tell us the reports, or you have them all here?
Yes. Sir.
Okay. All right. So you have done blood count, you have done renal function test, and you have done LFT. Okay. Yeah.
Yes.
Go through it. Yeah.
So here, complete blood picture is totally normal, and serum electrolytes are normal, and blood urea, serum creatinine are normal. Coming to the bilirubin value, total bilirubin is 12.63 mg per deciliter, and direct bilirubin is 6.65 mg per deciliter, sir.
So what does that tell you?
It is conjugated hyperbilirubinemia, sir.
So how do you define it?
So it's defined as greater than 2 mg per deciliter of direct bilirubin, or greater than 20% of the total bilirubin value, sir.
Excellent. Very good. Very good. Yeah. Go ahead.
And coming to the liver enzymes, aspartate aminotransferase and alanine transaminase, both the values are high, and alkaline phosphatase is also high, sir. Gamma glutamine transferase is 340 units per liter.
Is that
So
high?
what is that? As per your lab, is it high, low?
It is
So
high,
normal?
sir. It is high, sir. Very high.
Okay. So how do you suppose you have to summarize this LFT? How do you summarize it? You say that this is a cholestatic picture with a
It is a picture of conjugated hyperbilirubinemia with
high
alkaline phosphatase and gamma glutamyl with high
so
liver enzymes, sir.
So high GGT cholestasis. Yeah.
Yes, sir.
Okay. Go ahead. So what do these next 3-4 numbers tell you?
Coagulation profile is normal, sir.
And,
Serum
albumin, protein.
albumin is just at the edge, sir. 3.4 gram%, and total protein is slightly low, sir.
So what does this tell you? What does these 5 numbers, what do they tell you now together when you take it together?
So liver is gradually going into decompensated failure.
No, what parameters are these testing? What are
Liver
they looking
functions.
at? Liver function has many functions. The other, somebody else?
Synthetic function.
Coagulation.
Synthetic function.
Synthetic
function. So synthetic function is reasonably preserved. Yeah.
Yes, sir.
Yeah. Okay. All right. So this is you did all those blood investigations. Now what? Are you any wiser? Of your 4 differential diagnoses left? You have to speak, Harisha. Keep speaking. Don't have long gaps of silence. Yeah.
Yes, sir.
So what does it tell you? So it good bloods, good synthetic
I can
function.
rule out choledochal cyst in here, sir.
How come? How can you roll out choledochal cyst? You can't rule out, no? It is also, if the child has jaundice, that child also will have cholestatic jaundice.
Yes, sir.
Yeah, so you can't rule out anything here. Okay, so it's all your differential diagnoses are on the table.
Yes, sir.
Okay, then next.
So this is the torch profile of the baby, sir.
So are you just showing what they have done, or are you electively asking for these tests?
No, sir. I have asked for this test, sir.
You have asked for this test. Okay.
Yes.
So why did you ask for this test now as a priority? Dr. Ramesh just said, no, there is some urgency in the matter here. These tests take time, and they are not going to change anything dramatically in how you manage the patient. You need a key thing to freeze your, to confirm or indicate your diagnosis so you can proceed.
Yes, sir.
So what would be that test?
So first I'll get ultrasound abdomen done, sir.
Very good. Please go ahead. Tell us that first.
Show the ultrasound report.
So this is a ultrasound scan of the baby, sir, where the liver measures 7.1 centimeters. A gallbladder is partially distended with wall thickness of 2.3 mm, and there is minimal pericholecystic collection seen. There is no evidence of any space occupying lesion noted. And
so is this ultrasound you're happy with?
no, sir.
Suppose you have got to, your patient is admitted with you and you want to get the ultrasound done.
Sir.
And the radiologist from your hospital sends this report to you. You know, are you going to be happy or not happy?
I'm not happy, sir. I didn't get the information which I wanted.
Yeah, so tell us what you want.
So I'll see for the liver echo texture of the liver, sir, which is
You said it's normal.
It's normal. I'll ask for extrahepatic biliary radical dilatation, sir, if there is any. And
no, when you send a patient with suspected neonatal cholestasis and you're suspecting biliary atresia, you send this patient for an ultrasound.
Yes,
you know.
sir.
So what would you want to do? Would you want to send this patient? You know, in what particular state would you like
fasting,
to send this patient?
I want to send the child in fasting state, sir.
Yeah, correct. So you want to send this child in at least 2, 3, 4 hours of fasting. So and then you would do what? Sorry?
Check for the gallbladder.
Okay, whether and suppose it is distended, what would you do afterwards?
See for the contraction after taking feeds, sir.
Yeah, very good. Correct. Good. So when you send this patient to an ultrasound, fasting for 2-3 hours, let them do the ultrasound, and then after feeding, you see whether there is gallbladder contraction. So these are sort of fairly easy things to do. All right. Then so they are not able to see. They are just saying partially distended. There's some fluid. They are saying not very clear. No SOL. Any other thing that is standing out here? The spleen is there?
Yes, sir.
Spleen is there. Yeah. Okay. So now what next? Could this collection they are seeing be a perforation?
Maybe sir, it just
inflammatory.
Yes, maybe it's only a minimal collection. Maybe inflammatory.
You feel it is inflammatory from the biliary atresia pathology?
Yes, sir.
All right.
Because it's only a minimal and child has no any clinical features of any perforation. Or child is stable and all, with no tenderness, no signs of
theoretically,
yes,
you could have localized perforations. It's not necessary that every perforation has ascites.
Okay.
That is common, but you could have more localized perforation because it becomes a differential diagnosis of cholestatic cyst, isn't it?
Yes.
All right. So okay. So based on this ultrasound, now out of your list, what can you exclude? I think you have another 15 minutes to go through quickly about your management. Yeah.
We can exclude
cholestatic cysts.
Okay, you can exclude cholestatic cyst. You can exclude probably spontaneous perforation. All right. Then what next? What are you going to do next?
Sir.
Yeah, go ahead. Please answer whoever. Yeah.
I'd like to prepare the baby child for scan.
For sorry.
I would like to prepare the child for Bleeda scans.
For IDA scan, You are
Yes.
4-5 of you. Do all of you agree? Dr. Ramesh just made a point there when we started the investigation. Are all of you in agreement that you have to do IDA scan? What is the disadvantage of that?
Time it will take some.
Required at
We
least
have
5
to
to
wait for
7
5
days
days.
training.
Yes.
Yeah, so already you're saying that you're on the borderline of time and you don't want to spend another 7-8 days. It's doing IDA scan. The stool is all pale, you're saying.
Yes, sir.
Yeah.
I would go for a liver biopsy, sir.
You would go for a liver biopsy. All right. Why are you choosing that path?
Sir, to see the liver, how the liver is, so that is it amiable for a Kasai procedure, or we have to directly, if the liver is completely gone, there is no point in doing a Kasai procedure, and we can directly go for a liver
No, but
transplant.
what is suggesting to you that the liver is fully gone? What is the indication in your investigation so far to suggest that this liver is completely packed up and is cirrhotic?
Sir, in the ultrasound, we can know if the liver is completely cirrhotic.
Yeah, but you are
But
seeing an
nothing.
ultrasound. He's reporting it as normal.
Echo texture is
Okay.
normal.
Yeah.
Okay.
The echo texture is normal.
Echo texture
Synthetic
is
function
normal.
is.
Splenomegaly, INR is 1.1, and you're relatively well preserved with your albumin also 3.4. It's not too bad. So overall, it's not looking too bad at all.
Philip, will it confirm your diagnosis?
And
Can liver biopsy confirm your diagnosis?
In case of extrahepatic biliary atresia, it is a
it could still be an hepatitis, sir. So maybe the ideal would be, the gold standard would be an intraoperative cholangiogram.
Cholangiogram.
So why are you hesitating?
Yes.
Yeah. So here you have a case. You have a child who's at the borderline. Child is 100+ days. But seems to have preserved function. You think clinically it does look like biliary atresia. So rather than beating about the bush, you prove one way or the other quickly. If the child is high risk, then it's different. Yeah. So if you say intraoperative cholangiogram here, I don't think anybody will say you're wrong.
Yes.
Yeah. So
Okay.
let us say that you are going to do intraoperative cholangiogram. What are the prerequisites? What precautions will you take before taking a child with suspected biliary atresia for an operative cholangiogram?
Child has to be prepared with phenobarbital for at least 5 days, sir.
For what?
No.
For operative cholangiogram?
No, sir. No, sir.
Look for PT-INR.
Okay, you will check, make sure that the clotting is normal.
Clotting is normal.
You correct the INR. Okay, good. Any other thing you want to find out? Any other thing you want to find out? One of your differential diagnoses you said was hyperplasia Alagille syndrome. What do these children have? In addition to triangle face, which will help you make a diagnosis in this time, in the neonatal period. So do they have some cardiac anomaly?
Yes, sir. Pulmonic stenosis, sir.
Yeah, so you make sure that your child is not having any cardiac issue that is going to add some risk to the procedure. You correct the INR, you take the patient. Yeah?
Yes, sir.
So describe how you do the procedure.
With the baby under general anesthesia and supine position with bolster under the upper abdomen, we'll go for right subcostal incision, sir. And then intraperitoneally we'll identify.
Is it a classical incision or a mini?
Mini incision, sir. Almost.
That you have to mention.
Yes, sir.
Okay.
And then we'll identify the. We'll check for the liver and gallbladder, sir. We'll check if the gallbladder is atretic or if the lumen is present or distended. If the gallbladder looks atretic, then there is no point of doing intraoperative cholangiogram, sir. If there is voluminous or distended gallbladder, then I'll take a purse-string suture and introduce a venflon and then aspirate the. I'll check for the fluid aspirated. If it is transparent, then there is no point of intraoperative cholangiogram, sir. Directly we can go for Kasai. And if there is bile tint in the aspirate, then I'll slowly inject diluted contrast, sir, gastrografin or diatrizoid in a 1:1 ratio with normal saline. Slowly I will inject the contrast, sir.
So how long will you inject? How much are you going to inject? How much do you usually require to fill? Is it a very large volume? Is it a small volume?
Small volume is enough, sir.
So usually, the risk is not, the thing to do is not to over distend and cause leak. Yeah?
Yes, sir.
All right. So you have assumed, so you have opened this. The liver looks pretty good. It's cholestatic, but not cirrhotic.
Yes.
And the gallbladder is atretic.
Yes, sir.
Now what?
I'll go for the procedure, sir.
Yeah, ma. Don't drop a word and drop a line and then ask me to ask the question. Please keep speaking. When you say procedure means what procedure?
I'll go for Kasai portoenterostomy, sir.
Yeah, keep speaking. Don't stop.
Yes, sir.
So how do you proceed? Tell the Kasai portoenterostomy.
Yes, sir.
Extend the incision.
Yes, sir. I'll extend the incision and if required, partial chevron incision also, sir. Then I will release the triangular ligament to bring out the liver outside the abdomen, sir. And then.
So what precaution will you take when you do that?
So not to put too much pressure over IVC, sir.
So how will that manifest? That you're putting too much pressure on you're kinking the IVC. So you want to evert the liver outside the abdomen. So how will you know that you're causing IVC problems?
Increasing the out.
Yeah, go ahead. Who else is there? Speak up, please.
Hypotension. Lots of venous return, sir.
Increase in venous return, increase in the cardiac out.
So you get hypotension.
Yes, hypotension.
Yeah, so the patient will get hypotension. Okay. So you want to limit this time that the child's liver is outside the abdomen, and you only bring it out when the critical steps require you to do that.
Yes, sir.
All right. So you have done it. You have now come to then what next?
And then
Go ahead.
Keep going.
Harisha.
Yes, sir. I'll start dissecting. I'll start dissecting the gallbladder, sir.
So you need to see the porta first, isn't it? You need to see the portal structures.
Yes, sir.
So what is covering the portal structure? When you look at the liver and you lift up the edge of the liver, do you see the portal structures immediately, or you see some other organ?
It's a
Yeah, correct. Go ahead. Correct.
Hepatoduodenal ligament.
Hepatoduodenal ligaments.
Correct. So you have to divide the hepatoduodenal ligament. You have to pull the duodenum down. Then you start your dissection in the porta. Yeah?
Yes, sir.
So you will start with the gallbladder. Okay? So you tell me the extent. What is the cranial extent of your dissection? What is the caudal extent of your dissection? And side to side extent of dissection? You understand? You're taking out something, isn't it? That atretic stuff you're taking out. So what are the limits? So where is it caudally? Where is it cranially? And where is it side to side? In front and back is your hepatoduodenal ligament, is peritoneum. So what is it cranially, caudally, left and right?
Any other postgraduate?
Sir, cranially, we have to dissect up to the where the arterial ducts are fanning out to form a portal. Sir. There we have to transect near the porta hepatis.
No, so what is that? So how do you identify? See, you have to have a
Fanning out.
landmark. So what is the landmark?
Is it portal vein or is it a hepatic artery?
So branching, we have to laterally we have to see for the branching of the portal vein, sir, between the branching of the portal vein.
Correct. So laterally are the two branches. Okay. Yes. What is cranially? Where do you stop? Do you plow into the liver?
No, sir. Just
no. So where is that layer where you stop?
Glissen's capsule.
Very good. So at the level of the Glissen's capsule. So thereabouts. If you go through the Glissen's capsule, you are entering liver parenchyma, you will cause scarring.
Yes, sir.
All right. And then caudally?
We have to exercise the complete tract up to the.
Yeah. So usually it is somewhere in the lower part of the hepatoduodenal ligament near the duodenum. So that whole part you take out.
Yes.
Then what do you do?
We have to transect that tract at the level of the Glissen's capsule, and we have to see for the bile whether it is draining or not. Then I will prepare a Roux and Weil limb.
There is a lot of bleeding.
Sir, we must not use cautery, sir. We have to just put a mop, sir, to stop the bleeding, or use some.
Put a gauze and.
Surgical or abdomen.
No. What have you to do? Your liver is outside the abdomen. IVC is kinked. When your IVC is kinked, there is no venous return. Your liver is getting congested. So reposition the liver back inside the abdomen.
Okay.
All right. Then you do the rouleau.
Yes, sir.
Where?
Sir, from the 10 centimeters from the DJ, we have to divide the jejunum, sir. Then we have to take the jejunum along the avascular part of the mesocolon, go up to the right quadrant. Then,
so you go through the mesocolon or you go around? What are you saying? In
sir,
front of the colon?
No, sir. Through the mesocolon, sir.
Okay. So what is the length of the loop that you use?
40 centimeters, sir.
So what happens if it is too short? What happens if it is too long?
Sir, when there is too short, there is a chance of reflex of the enteric content, sir. So it may result in cholangitis.
Very good. What happens if it's too long? You take 80 centimeters. No cholangitis. So you are excluding large. So you are excluding large parts of the intestine from digestion.
Yes.
Yeah. So that you're going to end up with bowel that is going to be insufficient. You will have diarrhea and various things. Yeah. So 40 centimeters is good. All right. And then you will do a anastomosis. All right. So what is the usual outcome of these patients? What happens to these patients afterwards? Let us put it the other way. What is the various factors? How do you define a successful outcome? And what are the factors that help a successful outcome? What are the good prognostic markers and bad prognostic markers? First, you define what is the good outcome.
So when the child passes colic stools or green color stools immediately after the operation or 2 weeks within the post-operative period with decreasing bilirubin levels.
So it is decreasing. Level? So it comes down from 12 to 5 to 8. It is all decreasing.
Yes.
You do it after 2 weeks, it is 8. You do it after 4 weeks, it is 7. So you have to have some definition, isn't it? You can't go on.
What is the ideal? What is your looking at? Total serum bilirubin should be. It should come to how many milligrams to say it is successful?
Less than 1.5.
So you need clearance of jaundice. Means you should not have. So jaundice becomes visible after what bilirubin generally? So let us make it simple. You require a near normal liver function. By which time? How long?
Is it 3 months, 6 months, 1 year?
Usually
months.
apparent by 2 to 3 months, sir.
Okay, very good. So you want you want absence of jaundice, clearance of jaundice, and a near normal liver function or near normal bilirubin by 2 to 3 months.
2 to 3 months.
That is a successful Kasai. Yeah. Okay. So what are the factors that is good prognostic factor for successful Kasai? What are the poor prognostic markers for a successful Kasai?
Age at
Harisha?
surgery.
Yeah. Sorry?
The age at the operation, sir. That is.
Yeah. Clarify. Don't say age of operation and leave. You know, when you say what is your name, don't say my name is N and leave it. Finish it.
Within 90 days, when the baby is within 90 days at the time of operation.
Is 90 days what is written in, is what is thought, or what is ideal?
Less than 60 days, sir.
Yeah. So less than 60 days as early as possible. So if you operate less than 60 days, good prognostic marker. Then go ahead.
The clinical course of the patient soon after the operation, sir, if there are no episodes of cholangitis.
Very good. So if you have no cholangitis episodes, good. Multiple cholangitis episodes, bad. Then
the histology of the liver to begin with.
Like what?
If there is, if there is evidence of hepatitis or a liver cell inflammation.
No, I don't think that matters here so much. No. Then you're probably talking about a different pathology. It's not common to have inflamed liver and biliary atresia unless you have something else. You have cholangitis or something. What do you see in the liver? They give you a score. They give you an Ishak score.
The appearance of the remnant ducts, sir, within the liver parenchyma at the portal plate.
Okay, so that used to be something that people used to calculate, that if you see ducts beyond a certain number, it is good prognosis. What is that number? Do you know?
Not sure.
Okay, so 150 microns or thereabouts, but that's okay. That now again not very important. What in the liver? What does Ishak score measure? Do you know? Scarring. Basically, is there is fibrosis and scarring in the liver. That is good. That's bad prognosis. Okay. So if your liver is showing signs of cirrhosis or signs of severe fibrosis, bad prognosis. All right. So you said age at operation, recurrent cholangitis, liver biopsy. What else?
Can ascites make any difference?
It's a portal hypertension. If there is increased portal venous pressure, then also there will be more complicated. It's not Kasai is not successful.
Okay, so portal hypertension, maybe you will not proceed itself. Okay, then we discussed about the spleen.
Yes, sir.
So what is that? Is there any association?
Asplenia, polysplenia. What is the relation?
Have you heard of BASM?
Yes.
Splenic
malformation.
Splenic malformation.
Yes.
Is that good or bad?
Bad prognosis. Hypersplenism is bad.
Yeah. So if you have syndromic biliary atresia, it is bad. So those markers are spleen, asplenia, polysplenia, preduodenal portal vein, etc. So that is bad prognosis. So these are, so what you mentioned is correct. So age at operation, whether the liver is scarred or not scarred, whether the child has multiple cholangitis episode, whether you have cleared jaundice, and whether you have splenic malformation. These are all bad. Some are good, some are bad prognosis. Okay. So let us suppose that you have operated 100 such children today. What is going to happen as you go forward? Let us assume that you have operated everybody, at good time, all those things you have done. You have done a good operation. So one of the important indicators for success is your operation. So this is another procedure where the surgery itself, a well done surgery, has better outcome than a poorly done surgery. All right. So that please do not forget that it is important. That is why in a lot of countries, especially, they centralize. So there are a handful of people who do more and more of them because it does matter here. All right. So you have operated 100 children like this at 60 days of life, at 45 days of life, and they have all gone home. Now, what is going to happen to them as we go along?
1/3 of them will achieve good drainage, sir.
All right. So about a third will achieve good drainage and clear jaundice. All right. Then
another 1/3 of them will further deteriorate and will require a transplantation eventually, sir.
So about a third will improve completely and clear jaundice. About a third will show no response and will end up with progressive liver failure. And the third group, the remaining 1/3?
Continuous flow, no flow, intermittent flow.
Intermittent.
Yeah, speak up, speak up. Don't give one-word answers. Discuss.
They will achieve only intermittent drainage, sir.
Okay. So they will have intermittent drainage or fluctuating color of stool. There will be fluctuation in jaundice. They will get recurrent episodes of cholangitis. So this is a third group. So one group who is very successful, who meets your goal of normal liver functions at the end of 2 months.
Yes.
Another group that has mixed outcome, some reduction but no clearance. And a third group that does not clear at all, that has no change, just progressive worsening.
Yes.
Then what happens? What is the definitive treatment for biliary atresia?
Is the CASA is the definitive treatment or a stage?
No, sir, it is just an interim.
It just delays the for liver transplant.
So if you just stop sharing your screen, I think we can see everybody. I'm not able to see many people who are speaking. Yeah. So what happens to these people? So the people who have no success at all, that means the Kasai has not shown any improvement. After Kasai, there is absolutely no improvement. Child's liver functions keeps deteriorating. What happens to these children? Or for example, you have not done the Kasai at all. Child is 8 months old and has come to you now. What happens to these children?
They'll end up in kernicterus, sir.
Kernicterus, they will end up in? Why, man? Kernicterus happens when? And with what?
Bilirubin is higher than 20.
No, that's not the reason. So does conjugated bilirubin get across the blood-brain barrier?
Conjugated or unconjugated?
Unconjugated. Unconjugated.
Yeah, so that is something as
entirely a different.
So of these people will end up with liver failure, and if you don't transplant, majority of them will die before 2 years. Survival beyond 2 years in this group is almost unknown. All right.
Yes.
That is the patients who have just not responded. What about the patients who have responded well, who have successful Kasai? So the outcome that you measure is survival on native liver. How many people survive long term on their native livers?
It's about 40 to 60%, sir. 10-year survival.
Correct. So about 40% will survive on native liver for 10 years. But the native liver is not normal liver. It is cirrhotic liver, fibrotic liver. So they have problems. But yes, so what you're correct is true. What about the middle group?
Middle group will eventually go into failure by about 5 years, sir, and will require a transplant.
So why 5 years? What is special there?
Sir, it is because of recurrent cholangitis, which can be treated with a broad spectrum IV antibiotic if there is any infection, and they may again be normalized for a period of time.
No, I agree with your hypothesis that a lot of them will require transplantation in early childhood. All right, 5 years you have said. But I'm asking why that period?
Because they will still be intermittently draining, so the liver insufficiency will not progress progress at that fast rate.
So this is preschool, isn't it? So what happens at this age to a child normally? When they are 3 to 5 years, what happens? There is a growth spurt, isn't it?
Growth.
Yeah. So the liver is not able to keep up. So what you're saying is true. So the group that does not respond will fail usually by the first 2 years and will require transplant. And if you don't, unlikely to survive beyond 2 years. Those that have partial success, a lot of them will require transplantation during early childhood.
Yes.
Either because of recurrent cholangitis, because of growth failure, because of portal hypertension, because of progressive liver disease, whatever, usually by 3 to 5 years. What you're saying is true. And the ones who have a successful Kasai, about 40% are still on their native livers by about 10 years. Yeah. The remaining end up requiring transplantation for the same reasons. So I think last question and we'll wind up. We have overshot time. So what is your regular post-operative management of patients after Kasai? You operated the Kasai, patient is going home. What do you tell them? What's your management?
We keep the child on antibiotics, sir.
You have to specify. That is a very generic statement. What do you give meropenem?
No, sir.
So you will give antibiotic prophylaxis with
the drug which has to go into the biliary system.
Sulfonamide, sir.
Sorry?
Oral cephalosporin is given, sir.
Okay, so oral cephalosporin, first generation, second generation cephalosporin. You might rotate. Some people rotate between that and, as you said, Septran type things when they are a little older. All right. So you give antibiotic prophylaxis. What else do you give?
Polyuretic agent like ursodeoxycholic.
Okay. So you want to give a choleretic agent like ursodeoxycholic acid. Okay. What is ursodeoxycholic acid?
It stimulates excretion of.
What is it? What is it? Is it normally synthesized by your liver or something, or what is it?
It's a bile acid.
What bile acid? What bile acid? Bile acids are of different types. What are the native bile acids to you, which you produce? Homework. Okay. So what is UDCA? Where is it produced from? Why it is produced? What is its role? Okay. All right. Yes. Then. So read bile salt metabolism. Everybody reads bilirubin. You don't read bile salt. So please read the bile acids. Yeah. So it's a secondary bile acid and it is synthesized by your bacteria in the gut. It is not made by you primarily. All right. Okay. Then.
Any role for steroids?
Yes, sir.
So do you use in your setup? Do you use steroid or don't you use steroid?
We use steroids, sir. Our institution protocol, and we taper gradually over 2 weeks, sir.
All right. So you use a tapering dose. Okay.
Yes, sir.
So what is the literature about steroids? Is it found to be useful? If it is found to be useful, what does it help?
It is anti-inflammatory, sir.
Also choleretic.
So it is thought to help with early bile flow, but does not make too much difference in need for transplantation in the long run. All right. So that's sort of the more or less what people agree upon. So some people use, some people don't use. We use as well. All right. So antibiotic, choleretic agent, steroid. Then
fat soluble vitamins,
completely So fat soluble vitamins. Yeah, ADEK, because these people are going to be potentially deficient. And what else do patients with chronic liver disease, what else do they get?
Medium chain triglycerides.
Okay, so you might give diet which is based on medium chain triglycerides. All right. Then any other metabolic problem they are prone to? Also seen in children who have got renal disease.
Calcium.
So you can get osteodystrophy.
Calcium.
Yeah, correct. Osteodystrophy. So yeah. So all these you give. Yeah. So with all this optimization, these are the outcomes. All right.
Sir, hand out to Dr. Ramesh, sir.
Yeah, please. Yeah.
Dr. Ramesh Srinivasan.
So did you want me to actually talk about the cholestasis now? I think a lot of these issues are very well covered. One thing is about portal hypertension. In many
Sure.
of them, majority of times, usually up to the age of 2, they tend to be okay. But beyond that, the portal hypertension usually starts playing a big time. The first time we sort of banned most of them are between the ages of 2 and 3. So I've had a Kasai photo and me. Many times that occupies center stage after a while. Should I do the little presentation about it? Should we? Is the
Yeah. What we are interested is the flow chart, sir. Your priority of investigations.
Yes.
If you
I'll
get a
try and be
neonate
quick.
with cholestasis.
Yeah, I'll try and be quick. Yeah.
Yeah.
Okay. So basically, because all of you are surgeons, majority of you, so I basically come slightly differently in my approach. I'll start. Can you allow me to share my screen, sir?
Harisha,
Harisha.
Yes, sir.
screen sharing.
Harisha, make sir host, Harisha.
Yeah.
Yes, sir. Now you can share the screen, sir.
Yeah, I'm there. Are you able to see my screen?
Yes, sir.
Yeah, sir.
Yeah.
We are
So
able to see.
yeah, so this is going to be a whirlwind kind of tour of how we are basically going to do infantile cholestasis. We went through this definition that more than 20% of the bilirubin, if it's direct bilirubin, it's sort of conjugated hyperbilirubinemia. So the whole idea here is to be very timely, whether you're a medic or you're a surgeon, whoever you are. Basically, we don't have all the time in the world to do things, and especially so if it's surgical, we want to do it on time within an appropriate time frame because we know that we want to actually catch it on time and operate within the required time frame. Medically, also there are lots of important emergencies which are related to infantile cholestasis, which we will see in the slides to come. So in biliary atresia, you run out of time. You can avert damage to the liver in galactosemia and thyrosidemia by diagnosing them early because the liver will suffer damage. They go on to have chronic liver disease even after you have diagnosed and put them on the appropriate treatment. Especially galactosemia, if you diagnose them early and treat fine, but if it's later, they still carry some signs of chronic liver disease or cirrhotic damage. Some causes are easy to treat, like hypothyroidism and urinary tract infection. They also cause conjugated jaundice. Now, the first step here is always to say whether this is a surgical baby or a medical baby. Many times people say surgical babies are not very unwell when they present. It is true in the majority of cases. Sick and well infants who have cholestatic jaundice, majority of the surgical babies apparently seem to be well at the time when they present compared to the medical kind of presentations. Now, we discussed so many things here. We went through a case history, prematurity, parental nutrition, sepsis, blood group incompatibility are all very important. Prematurity, use of parental nutrition, sepsis, many times causes cholestasis because many components of PN can be damaging to the bile ducts. Presence of hepatomegaly and splenomegaly we saw. Presence of a splenomegaly and hepatomegaly could be suggestive of storage disorder. Establishing portal hypertension may actually cause a splenomegaly. Presence of ascites means portal hypertension and decompensation is set in. Cardiac signs, if they are there, we are basically thinking of conditions like Alagille syndrome, or could be other dysmorphologic syndromes where heart conditions are associated. Multi-system involvement always brings into our thought about the intrauterine infections. Currently, CMV is one of the most important intrauterine infections. Most of the other intrauterine infections are not very common. I will show you in the subsequent slides how a medic thinks about these conditions because bleeding is also very, very important. Sometimes children present with gross coagulopathy and liver failure. So, and usually happens in medical conditions like a hepatitis syndrome. Itching and scratch marks are physical signs we pick up. They go very specific with some conditions, most likely a PFIC or Alagille syndrome, where itching occupies center stage and may be the sole reason for a transplant for some conditions. So Now, the yellow alert is very important. All of us basically should inspect the stool of every baby with cholestatic jaundice who has come. One important thing which was missing in the presentation is actually an inspection of the stool, which should form part of our evaluation. Merely taking a recorded history is not good. And the color of the stool should be yellow or in the shades what basically is shown here. Shades of beige, shades of white, cream are not acceptable, magnolia, etc. So, in the surgical etiologies, you have considered at length, extraparticular choledochal cyst, and other differentials like bile duct stenosis, cholelithiasis, spontaneous perforation, etc. I won't go into the details. Ultrasound abdomen should be done after 4 hours of feeding, and that basically should demonstrate a well-defined gallbladder, contracted gallbladder, irregular gallbladder, undefined contents, extraparticular apparatus always bring about suspicions of biliary atresia. And a hepatobiliary scintigraphy, if you actually have a bit of time on your hands, yes, we can do it after pre-medication with phenobarbital, 5 mg per kg in 2 divided doses. And if it shows excretion within 24 hours, it means excretion is happening. Ideally, excretion should happen within 4 hours after you give the contrast into the system. But in case the liver is diseased, or in cases of biliary atresia where there is documentation, we won't have any excretion after by 24 hours. By 24 hours, if you have not had an excretion, the scan is reported to be suggestive of biliary atresia. And liver biopsy is useful once again if you have time on your hands. And there basically we're looking for portal expansion, proliferation of bile ducts, which are important findings in biliary atresia. You may also find some other findings of a minimal hepatitis around the portal tracts. Intraoperative cholangiogram, you described it, is going to be very important even on the operative table to make up your mind whether it's biliary atresia or not. So in India, 1/3 of all cases of neonatal cholestasis is going to be biliary atresia. And this basically have been from studies which are 10, 15 years old, but still it holds true that at least 1/3 to 1/4 of all cases of cholestasis are biliary atresia. So this remains one of the most important diagnoses. The other important diagnosis is idiopathic, where you have investigated such a lot and you haven't actually found a particular cause. But with genetics and with the metabolic workup being so good, we are diagnosing more and more cases in our clinical practice. So important thing in I wouldn't do so much about biliary atresia. I would go into the medical conditions now. Now, in medical kind of cholestasis, important conditions to recognize which present as acute liver failure or severe coagulopathy, where once again you are handling a medical emergency, just like how we are handling a surgical emergency, is to look for galactosemia, which can present with acute liver failure and severe coagulopathy. Next thing is, among the intrauterine infection, herpes can present with severe coagulopathy and acute liver failure, and institution of IV acyclovir is very gratifying. Other conditions which are medical emergencies related to neonatal cholestasis are neonatal hemochromatosis, tyrosinemia, neonatal sclerosing cholangitis, and obviously hemophagocytic lymphohistiocytosis and metabolic disorders, including mitochondrial disease. So the list is 5 or 6 only, presenting as acute liver failure or severe coagulopathy in the neonatal or early infantile period. So important differentiation in the mind of all of us should be surgical versus medical. And if it's surgical, first extrahepatic biliary atresia, choledochal cyst, and the others which are described. And next is basically the medical conditions. Medically, there could be important conditions which may require immediate attention also, which have to be kept in mind. So a practical approach would be, there are lists and lists, and there are so many algorithms, and sometimes these algorithms are actually confusing. But each of us develops a particular kind of way we want to handle these kinds of patients. So first thing is to get an LFT to say whether this is a conjugated jaundice, whether there is a significant amount of conjugated jaundice for us to think this is neonatal cholestasis, including gamma GT. Many times, all labs, they don't do gamma GT. Gamma GT is very important for us to know. You have seen in this case of biliary atresia, both gamma GT and alkaline phosphatase, both are elevated. So you should know a condition where gamma GT is not elevated when you have elevated alkaline phosphatase. Low gamma GT cholestasis is actually very, very important for us to recognize. Goes in favor of PFIC type 1 and type 2. Progressive familial intrahepatic cholestasis. So this is very important. PT-INR, this will tell us the latest synthetic function about the liver, how the liver is working in the last 12 to 24 hours. We will know about it. INR more than 1.5 is troublesome. So stool inspection has to be done at the bedside, and the nurses have to keep the stools for inspection. Ultrasound abdomen, we said, in the first set of investigations itself, ultrasound abdomen should come. Partially contracted gallbladder, non-visualized extrahepatic biliary apparatus after 4 hours of fasting, should ring the bell about biliary atresia loud and early. Next is HIDA scan. If you have time, you should do a HIDA scan. No excretion by 24 hours. Biliary atresia, top of the mind. Thyroid function test, urine cultures usually done right at the beginning because they are correctable, treatable causes and will basically reduce the neonatal cholestasis very, very easily. Very important to note, urinary tract infections are notoriously common and they are important causes of the medical causes of neonatal cholestasis. Torch screen, I would say we do so many torch screens, but the yield is actually very little. I will go into torch screens in detail a little bit later. Second line investigations would include other causes. Eye examination to look for posterior embryotoxin, chorioretinitis, as in cases of intrauterine infections. 2D echo to actually look for peripheral pulmonary stenosis or PDA or VSD or other malformations like AVSD, etc. Extended metabolic screen. This is actually quite important in the medical scenario because we have got undiagnosed amino acidopathies, organic acidurias, fatty acid oxidation defects which can present with neonatal cholestasis. Now, liver biopsy, I'm going to give 2-3 slides separately for this to actually work up on the liver biopsy and why we should do a liver biopsy and when we should do a liver biopsy. And last of all, genetics has come quite handy in cases we are struggling, are basically our head against a wall, then many times genetics do unravel some things and give us an impression of what we are dealing with. So the idiopathic fraction is actually coming down because of genetics, what we are able to do these days. So if you are actually looking at a flow chart or a diagram, so in conjugated hyperbilirubinemia management, we basically do an LFT, prove that it is conjugated hyperbilirubinemia, look at the PPINR, to look at synthetic functions, look how unwell the child is, do an ultrasound early, if necessary, a HIDA scan, look at surgical and medical as separately at that particular point. If it's surgical, there's always a level of anxiety and a level of urgency about it to sort it out because we run out of the time scale. We want to do everything within the 60-day period. Now, among other things, when you come to the medical, there are so many different causes. And in the medical also, first we should think about the emergency conditions. Galactosemia, tyrosnemia, neonatal hemochromatosis, neonatal sclerosing cholangitis, and we are thinking about herpes as the most important intrauterine infection, which can be dangerous to the baby. So this is our first thing on the head. On the ultrasound, if you're able to see a colorectal cyst, yes, surgery. If you're seeing an absent or contracted gallbladder, then once again, this basically goes towards biliary atresia. And then it has to go through the surgical route. If there is time, HIDA scan. Otherwise, you go for an intraoperative cholangiogram and decide on the table whether this is an extrahepatic biliary atresia or not. That is the final port of call. And if it's not sort of biliary atresia, then you have time on your hands to actually work it up, whether it is at what medical condition is it and what medical condition it's not. An important thing here in the flow chart is using a liver biopsy. If you have a bile duct paucity, we are thinking in terms of Alagille syndrome. Now, Alagille syndrome many times can present just like a biliary atresia. And one more thing which can present just like a biliary atresia is CMV also, which can present like biliary atresia. Biliary atresia is important diagnosis. Until the last minute, we have to chase it to the bitter end to actually prove it is biliary atresia. And on the table will be the last port of call. And this is very, very important. And our 60-day deadline should be taken as very, very important. So lots of flow charts, but the important thing is going through in our mind, because these flow chart, this is a flow chart we use in our department so that we don't miss out on any conditions which have to be looked at. And so it's a useful aid memoir also for us to actually slot it and actually plot these values here so that it will come very handy. So there are some key clinical and laboratory features to find out what the causes could be, to make up our mind, to fine tune the investigation. There are 30 odd different investigations to be done. And most of the times, I would say that when you are practically on the ground, we do deal with lots of families who have got financial difficulties, etc. So we have to tailor our management depending on what we find. And majority of cases, you may actually find these things as we actually look them for. Now, this is my vision. Acolic stools, not only in biliary atresia, you can see in colorectal cyst also, neonatal sclerosing cholangitis also. Acolic stools can be seen in cases of Alagille syndrome also. Acolic stools can be seen even in cases of PFIC, which are severely affected. You can see acolic stool. But in acolic stool, our first priority is biliary atresia because you have got a time scale to deal with. So this is very important. Second, sick infant, think in terms of metabolic liver disease. I know there are some DM neonatology students also in this particular webinar. So metabolic liver disease, galactosemia, tyrosnemia, NHC, very important, fatty acid oxidation defects, torch infections, among them top priority, herpes. CMV can also cause severe liver failure. It can also cause decompensated liver disease that stays next in our mind. Pruritus, very important. PFIC and allergies, they present with pruritus. Children will be scratching themselves, not able to sleep, and pruritus occupies center stage not only for the infants but also for the families. The whole family routine will run around the pruritus. Now, ascites, usually presentation with ascites is bad news, and usually can be present in any decompensated liver disease can present with ascites. Biliary atresia left for a long time can present with ascites also. Metabolic liver disease usually tends to present with ascites. So this is very important. Dysmorphism we discussed in the case discussion. Allergies, yes, we said, okay, triangular faces, broad forehead, little bit of a hypertelorism. So these are there. But Down syndrome can present with a congestive hepatomegaly. They can have AVSD or they can have a VSD and they can have pulmonary hypertension. They can present with liver problems also. Paroxysmal defects like Zellweger, rarely you can pick it up. And there are some conditions like GM1 gangliosidosis. They can also present with dysmorphism. Cardiac conditions, so many of them. Alagille syndrome, peripheral pulmonary stenosis, congenital rubella. Luckily, it is so rare now because of the MMR vaccinations. They can have this classical PDA. They can also have tetralogy of Fallot, ventricular septal defect. Biliary atresia, we discussed. Biliary atresia, you said you wanted to actually get the 2D echo done before you take them for an intraoperative cholangiogram. Bowel preparation is necessary before an intraoperative cholangiogram. And here, biliary atresia patients may have situs. I have seen so many children, at least 10% of biliary atresia will have malformations related to either situs solitus, situs inversus, dextrocardia. They may also have abnormalities like VSD, atrial septal defect. So very important, even in biliary atresia, to get the 2D echo done. Eye findings in galactosemia, you may see an oil drop cataract. Posterior embryotoxin, little difficult, but you may see it in Alagille syndrome. And chorioretinitis in conditions with torch or those with cherry red spots. Vertebral defect, if you get a plain X-ray of the chest, you may see hemivertebra. And that may go with Alagille syndrome. Lymphedema with a different condition called Agnes syndrome. Now, we did mention about metabolic bone disease as a consequence of the poorly treated biliary atresia because the liver is not absorbing the vitamin D. Now, rickets and renal tubular acidosis could be presenting features of tyrosinemia. This is very important. We have picked up so many children who basically presented with rickets, and they usually have a proximal renal tubular acidosis. They are losing a lot of their glomerular filtrate in the urine. They will lose phosphate, they will lose calcium, they will lose amino acid, they will lose glucose, and they will be passing lots and lots of urine. So renal tubular acidosis and rickets, you can actually point out towards tyrosinemia. Tyrosinemia always doesn't need to present right very, very early. Even recently, we had a case from Dr. Narendra Kumar. We did a liver transplant for tyrosinemia case, and she has got a very classical type 1 renal tubular acidosis. Now, low gamma GT, we said alkaline phosphatase is up, gamma GT should also be up. But if gamma GT is disproportionately low, ring the bell. PFIC type 1 and type 2, Byler's disease and BSCP deficiency, they present with low gamma GT. And low gamma GT also seen in other condition called bile acid synthetic defect, metabolic defect. But important differential is bile acid synthetic defect children do not have pruritus, but PFIC children are reaching all over their body. So there are some clues which will tell us that this is this and this is not that. Maybe the medics will like this information more. Hyperammonemia. In a child with cholestatic jaundice, if you have hyperammonemia, immediately you're thinking, is it urea cycle defect? Is it something else? There is one condition called citrin deficiency, which can present like this. It works as an aspartate pyruvate shift in the metabolic cycle, in the Krebs cycle. And the citrin deficiency can present with hyperammonemia. It is very rare, luckily, in our particular environments. Hypoglycemia can happen in most organic acidemias, amino aciduria, fatty acid oxidation defects. So these are very important here. Let's go into the next slide. So allergens, we said, we talked dysmorphism. So dysmorphism, very, very important. This is the triangular faces, and this is the chin, which is very, very pointed, and the relatively spread out camti. This is the relative hypertelorism. Look at the scratch marks here. This is basically the pruritus, which is basically causing the scratch marks. Here, this line here is the posterior embryotoxin. It can sometimes be visible even with a torchlight. This is where the cornea basically blends into the ciliary apparatus, the choroid, and you can actually see a line. They say this is actually in a place where you normally should have a Schwabel's line. That's where you see this white line here. You know about the heart defects which can go with allergens. The most famous of them is the peripheral pulmonary stenosis. But allergens is an autosomal dominant condition with a variable penetrance parent. One of the parent may also have the allergens gene. They may or may not have a particular problem because of the varied expression. I've had one particular condition, one child, where the child was diagnosed with allergies, and 2 or 3 weeks later, the mom had a cerebrovascular accident because she had an aneurysm in the circle of Willis. So vascular malformations also are very much known. Allergic syndrome used to be called arteriohepatic dysplasia. So vascular malformations are also very common. Moya disease is also very well known, and vascular malformations in many organ systems of the body, including the brain, are known. Cerebrovascular accidents have happened in adults with allergies. Abnormalities of the renal system are also known with allergies. So allergic syndrome can present intense pruritus. Bile duct paucity can be there. They may also have a poor uptake on the Hyder scan. So it's very important for us to know some mimics for EHBA also. So many etiologies. There are 30, 40 different conditions which can cause a hepatitis syndrome. So if you differentiate the surgical ones out, then you're left with lots of conditions which basically cause medical causes of neonatal hepatitis or infantile cholestasis, which we have to look at. They could be infectious, like a torch infection. It could be simple infection, like a urinary tract infection, simple sepsis. A baby who has been in PICU, a prem baby who has been there for long, hit by several episodes of sepsis, and also parenteral nutrition. They may have cholestasis, and this cholestasis tends to resolve gradually over a period of time. It could be toxic because of the parenteral nutrition. Hematologic kind of conditions, blood group incompatibility, where basically you have inspissated bile because they have produced so much of bilirubin because of the red blood cell destruction. This may actually clog up the whole bile duct. Many times, all the senior surgeons would have remembered, many children have actually gone on to theatre for intraoperative cholangiogram. And once the catheter went into the gallbladder and they flushed it, and they said successful flushing of the extrahepatic biliary apparatus. So no Kasai was done. So the child sent back with a wedge liver biopsy. Sometimes inspissated bile syndrome, they do very nicely from that particular time on. So these are actually some very nice conditions where inspissated bile can be flushed and they actually are well. But sometimes inspissated bile with the choleritic agents, what we use with some phenobarbital and UDCA, they tend to resolve over time. Endocrine causes, hypothyroidism, hypopituitarism, hypoadrenalism, all of them can cause cholestatic jaundice. Metabolic conditions which have organic acidemias, amino acid ureas, urea cycle defects, and rare conditions like citrin deficiency, and some storage disorders, especially like GM1, GM2 gangliosidosis, Niemann-Pick's disease, Couch's disease. Cholesterol ester storage disease like Wolman's disease can also cause neonatal cholestasis. And genetic and chromosomal diseases are very important. And finally, I've put in bold letters idiopathic. Despite our knowledge of genetics, metabolic, all the surgical, what we do, there is a percentage of children with neonatal cholestasis, infantile cholestasis, who do not have a diagnosis. This only says that we are yet to learn quite a lot about what's happening to the liver. And that is very humble, and that is true. So among other conditions, one important condition I want everyone to know is cystic fibrosis. In the particular talk, you did mention the child passed meconium at birth. Delay in passage of meconium, one of the important conditions we should think about is cystic fibrosis. Cystic fibrosis presenting as neonatal cholestasis or infantile cholestasis is also possible. And there are many children with cystic fibrosis who have been picked up just like that because of infantile cholestatic presentations. Allergic syndrome and all these things. Yeah. Now, importantly, I want to talk a little bit about PFIC because progressive familial intrahepatic cholestasis conditions are a huge chunk of disorders where a lot of children undergo liver transplants. And it's known that some conditions of PFIC are more troublesome than the other conditions. Now, progressive familial intrahepatic cholestasis now used to be classically a 3 different type of disorder, PFIC type 1, type 2, and type 3. But with more and more genetic descriptions, there are almost 7 different common types of PFIC which are known. But the most significant of them are 3, type 1, type 2, and type 3. Type 1 and type 2 present with low gamma GT cholestasis, while type 3 has got a normal gamma GT cholestasis. Pruritus is intense in type 1 and type 2 PFICs. And these kindreds are described all over the world, including in our own state, our own city. We have lots of cases of PFIC. And PFIC, a good majority of them undergo liver transplants for their condition, and sometimes not for liver failure, just for pruritus also. So among the three types of PFIC, type 1 PFIC is called bilous disease, where granular bile is noted in the biliary canaliculi, and they have low gamma GT, and the progression is a little bit slow compared to type 2, which is called DSCP deficiency, bile salt exporter pump deficiency, and these tends to be the ones who proceed rather rapidly to a liver failure, and they also suffer intense pruritus. A slightly increased chance of a hepatocellular carcinoma is also known as PFIC type 2. So suffice it to know that always get gamma GT along with alkaline phosphatase, and in case the gamma GT is disproportionately low in a child with the cholestasis, think about PFIC. So rarer conditions are hemophagocytic lymphohistiocytosis, neonatal lupus. Neonatal lupus usually happens following a maternal lupus, and usually they tend to clear these antibodies acquired from the mom within 6 months' time, and the liver functions usually come to a normal by then. So intrauterine infections, I want to have a special word because we do so many TORCH investigations and the yield is rather low. And among intrauterine infections, toxoplasma, rubella, and syphilis fortunately are rare now. So we do not have too much problem with them. Why these are all grouped into one group? Because they present similarly. They have hepatosplenomegaly, skin rash, anemia, pneumonitis. Some may have seizure problems because of CNS affection. They may have microcephaly, hydrocephalus, sensorineural hearing loss. And for example, specific ones like rubella may have the kind of cardiac defects and the cataracts, etc. So important thing for us in the current day scenario, herpes, both type 2 herpes and type 1 herpes, especially in those vaginally delivered children, they may actually present with severe coagulopathy and liver failure. You may not find a rash on the body at all, but IV acyclovir works wonders for such children if started early. Now, one important thing is about congenital CMV. I've seen a lot of papers and clinical presentations where say, oh, we have had 5% congenital CMV in this particular scenario and not. CMV is overdiagnosed. CMV is the most common intrauterine infection, but majority of congenital CMV, even if they're diagnosed, do not cause severe hepatitis. This is very important. Now, I've done a lot of presentations, and most of the times, whenever CMV IgM is positive, immediately they jump and say the hepatitis is because of CMV, which is not true. So, for CMV hepatitis to be proven, you should get CMV from the urine. You should have an increasing titer of IgM. For congenital CMV, you should prove that they have had significant high levels of IgM within the first 3 weeks of birth. Otherwise, postnatal CMV can also mimic just like a congenital CMV. And importantly, if you get a CMV PCR, DNA, and that if it basically showing in several thousands or millions, then you're more likely to say that there's an active replication of this particular virus. And if you have elevated levels of transaminases, and if you're fortunate enough to be able to do a liver biopsy and prove that there are possibly changes suggested for CMV. Now, important to know that CMV hepatitis, to diagnose it, you will not always find the typical owl-eyed inclusions which are seen in CMV. You can do a CMV staining or an immunohistochemistry on that. And if you demonstrate a CMV with a CMV PCR, which is positive, with associated abnormalities in the LFT, then yes, then you can say this is CMV. One important pearl I want to give to all of you surgeons is CMV and biliary atresia, they can be partners in crime. And this is very, very important. Don't rule out it as CMV and send it away. If you think ecolic stools are there, chase it to the bitter end and check it out that there is no biliary atresia. We know that Rio virus has been implicated in biliary atresia. CMV is also implicated in biliary atresia. And we know that biliary atresia is sometimes a progressive fibrosing cholangiopathy. And this has started in the late intrauterine life, which is basically continuing into the postnatal age. And CMV could be an associated culprit in this scenario. So always rule out biliary atresia clearly in CMV cases. Don't just say CMV, go away, ganciclovir, valganciclovir, and get better. Most of the times when you have proven CMV hepatitis, treating them with ganciclovir IV for 3 weeks, then valgan for 3 weeks, usually gives good results. Rarely does a CMV hepatitis land up in such a decompensated state to actually result in liver failure, death, or go on to transplant. But these have happened. So it's very important that in our particular scenario, congenital CMV and herpes are the most important intrauterine infections. And the toxo, rubella, and the syphilis are possibly not the big players in our current medical practice. This is very important. Now, next is liver biopsy. Someone talked about liver biopsy. Liver biopsy for biliary atresia. Yes, if you are thrifty, you have the time on your hands. Yes, go ahead and do a liver biopsy. Now, in liver biopsy, we said basically expansion of the portal tracts. and basically you have got a multiplication, or you have got an increased number of bile ducts. If it is there, yes, it may go more with biliary atresia, but no pathologist will say, yes, this biopsy is biliary atresia. We have to put everything together. It's like putting pieces of a jigsaw together. And with biliary atresia, we are like Sherlock Holmes. We have to actually go and check it out on the operating table that finally, yes, it's biliary atresia or not. Now, liver biopsy basically is helpful in so many other conditions. So many types of liver biopsy are also there. What we medics do is a percutaneous liver biopsy. Most of it do it with a true cut needle. Some people in some centers use a suction approach called the modified manganese approach. What we do is mostly what is called a spring-loaded true cut approach. That's what we do. We try to get a good core. So we have to know what is a good liver biopsy. When should you do a liver biopsy? Or first of all, when not to do a liver biopsy. Now, important thing is, if your INR is more than 1.5 and your platelet count is less than 70,000, do not attempt a percutaneous liver biopsy because it can be very dangerous. If there is bleeding, you will not be able to control, and there could be a huge intraperitoneal bleed, and hypotension can be so severe. Liver biopsies, very importantly, can be really dangerous also, especially if you're doing it blind. So these days, the standard of care is to do an image-guided, targeted liver biopsy. If you're able to do the the ultrasound yourself, well and good. Otherwise, we normally get a spot marker for a liver biopsy, usually on the mid-clavicular line. And we also get a depth of the throw. How much can you actually go in to actually get a liver biopsy? A good liver biopsy is something which is almost around 20 millimeters length and 1.8 millimeters width. It should have, in the adult field, at least 11 portal tracks for the pathologist to give you a good impression, or in pediatric practice, minimum 6 portal tracks for you to get a good liver biopsy. And it's very, very important that the right approach is taken. Now, sometimes you cannot do a liver biopsy. There's a child with acute liver failure, INR is more than 1.5. You cannot do a liver biopsy because of the dangers associated with it. If there is a good radiologist who's ready to do it on a little fiddly infant, he can do a transjugular biopsy. But in our particular setting, we do not have the required kind of apparatus and the materials to do a successful transjugular liver biopsy in a small baby. So sometimes we have to rely on other investigations to try and get to the point to try and make a diagnosis also. So important to note that little babies with acute liver failure, you may not be able to do a liver biopsy, and sometimes putting them on an empirical treatment or by trying to arrive at a diagnosis by investigations or deduction is particularly important. Now, many times when children go, for example, in intraoperative cholangiogram, the bile ducts are flushed brilliantly. They tend to give you a wedge liver biopsy. The surgeons give us a wedge liver biopsy, which is a surgical liver biopsy. And that is actually very beautiful. We can actually get so much of information from that. So liver biopsy, never attempt it if the INR is more than 1.5 or the platelet count is less than 70,000. And basically, you should be well experienced in doing the liver biopsy. And image-guided liver biopsy is the standard of care. Or sometimes interventional radiologists can do it for you if you're actually very lucky in your departments. So basically, sort of these are a few pointers. This is actually one of the classical lobules what we have here, and this area is called the portal area. And this is basically where the central vein is. I'll basically show you better pictures there. So portal area and the central veins, we basically need to look at that. Now, what happens is in the portal area, you basically have 3 structures. You basically have a very nice rounded structure with lots of collarette of cholangioles. This is basically the bile duct. And here you have the hepatic artery branch, the arteriole here, which is very, very round here. And then this is the portal vein, which does not have such a rounded wall, and you have few red blood cells in it. So it's important to actually look at the lobule, where you have the portal areas, and you have the lobule, which basically people loosely refer to how the hepatocytes are, how the sinusoids are, and how the space is, what is the level of inflammation in the lobule, and to see what kind of cells are infiltrating the lobule. Are there any additional things like pigments, etc.? What is the level of reticulin there to say what is the level of scarring happening in the liver biopsy? So for example, this is a biliary atresia case where you have expansion of the portal areas, and you have basically ductal proliferation of the bile duct, which is seen in biliary atresia. And this is what the pathologist tells you. Important to note, these days where MRCPs are possible, there's a high sensitivity and specificity for MRCPs also, if they can be successfully done in little babies, and they may also define the extrahepatic biliary apparatus with a fair bit of success, about 90% or so. So that is also being used. Now, sometimes the liver biopsy is also used where you do not find bile ducts, but there's a paucity of bile duct. You basically find this portal one, you basically find this portal vein radical here, you find the arterioles, but the bile ducts go missing. So in some cases of Alagille syndrome, which is a syndromic bile duct paucity, or this non-syndromic bile duct paucity also, where you can lose that. And sometimes the bile ducts are surrounded by an onion skinning of inflammation, like a neonatal sclerosing cholangitis. So what I basically said, this is actually an example of a PFIC, where you have what is called a lobular disarray, and you have some giant cell formation, like what you see. So the liver biopsy is very useful, but you need to have your clinical cards really clear. And the liver biopsy is an adjunctive piece of information which will help you make up your mind. So the whole idea of this neonatal cholestasis is there are 30, 40 different types of disorders. First thing is to check whether it's surgical or medical. If it's surgical, get the ultrasound. If you have time, hide a scan. If you have time, get liver biopsy. But the decision, it happens on the operating table. Next, if it's medical, first check it out that you're not dealing with a very sick or a dangerous situation, a severe coagulopathy, where you have to treat someone and make them someone better. If they're okay, then you may actually want to go through the role of the whole gamut of investigations, tailoring it to the right kind of patient with the right kind of symptoms, depending on what clinical features we discussed, and then basically sort of taking a step-by-step approach and confirming it, including doing tests like liver biopsy in a safe manner, and then thus confirming a diagnosis. So we come back to this algorithm here. So basically, infantile cholestasis, then see alpha-1 antitrypsin, we do not do it here so much because it's a Caucasian gene, and we do not have alpha-1 antitrypsin deficiency hugely here, causing infantile cholestasis in India. So basically, sort of coming back to the last slide here, going back to this algorithm again. So here we are saying some metabolic tests are important, like galactose 1-phosphatidylidyl transferase, plasma amino acids, cholesterol, triglycerides, serum ferritin, etc. And the ultrasound of the bile ducts, hide a scan, etc. Trying to get up your mind whether you're surgical or not, whether you're severely medically unwell, sick child. Otherwise, you basically sort of try and look for the other conditions, confirm a diagnosis, and treat them. Sorry, I've been a little quick. The subject is huge. I do not know, but anyway, this is all what I had to say. Please ask me questions if you want more clarifications. I'm glad to share. Thank you.
Thank you, Dr. Ramesh.